Hey folks, in this presentation we're going to talk about drowning resuscitation, primarily from a pre-hospital standpoint. So the main thing you need to walk away with today is this term hypoxia and what that means. That means a lack of oxygen. If you take nothing else away from this entire presentation, as long as you understand that hypoxia is the leading cause and primary cause of morbidity and mortality and drowning, and that your focus of treatment is reversing that hypoxemia or hypoxia, then you understand the treatment of drowning, and you're far beyond what most people understand. So again, just take away the point that hypoxia is the primary cause of morbidity and mortality, and reversing this hypoxia has to be our goal of treatment. I always like to start off with a quick introduction to the history of drowning resuscitation, just because it's kind of interesting. This is a depiction of drowning resuscitation from 1237 BC. The Great of Aleppo, outlined in blue there, fell into a river and drowned during a battle. On his left and right, outlined in red, are guards holding him upside down, the idea of ridding the lungs of water. It's the earliest depiction of drowning resuscitation that we have. As we progress through history, we now have some early depictions of some other treatments. On the left, we have holding someone from a fire, the idea that smoke being a stimulant might stimulate life. Up in the upper right, we have, again, putting someone on their belly, having gravity help flow water out of their airway. On the bottom right, we have early forms of Heimlich maneuver and CPR, putting a patient on top of an animal and having that animal run, causing some compressions of the abdomen and the chest. This is always everybody's favorite. This is the tobacco enema. So the idea behind this, again, tobacco is a stimulant, but this person is dead. How are they going to smoke? Well, you shove a tube up their ass and you smoke for them. And this is where the term blowing smoke up someone's ass actually came from. And this was the popular treatment of the time. As we get into the early 1900s, these are official Red Cross and government videos showing early forms of CPR, the Schaefer method. So this was cutting-edge stuff in the early 1920s, and this is how drowning patients were resuscitated and treated. Moving through the 1940s, this is from Popular Science magazine. So again, this is cutting-edge science here. On the left, again, we're seeing the Schaefer method, the idea causing some rib raising, essentially, and passive ventilation to the patient. On the right, we have the Eve method. So for that lifeguard who has some extra time in their hands to build a simple machine, the idea being now you can rock the patient back and forth. And again, that would hopefully encourage water to exit the airway. Now, obviously, science and technology has come a long way. We have fast boats. We have Emily, which is a robot that goes out and saves people. We have drones that are used, helicopters, ECMO, Lucas devices, all these fancy things. So why do we keep talking about this? Haven't we figured this out? Well, the truth of the matter is we haven't come close to figuring it out. Around the world, it's important to keep in mind that 91% of drowning deaths occur in low and middle income countries. So yes, this is a problem in the U.S., but it's a much bigger problem other places. Some societies, water sustains life. It allows for fishing to get food, it allows for bathing, it allows for cleaning clothes. There are multiple bodies of water without any boundaries around them or barriers that kids play around. So this is a problem in our country, but a much bigger problem around the world, and we have to kind of keep that in focus. Now, I would just like to put up a quick warning that the videos coming up are going to be pretty graphic, but I think the best way to learn anything in medicine is to see some real-life scenarios. So here we see a video of some military police, and they have pulled a child out of the water, and their first action is to hold that child upside down and try to rid the lungs of water. So you can see I have multiple people here holding him upside down, shaking him up and down, doing the best they can. But this is no different from the way we're treating people in 1237 BC. Now here is a very interesting video. If you watch the whole video, there's a boat that capsizes off the beach, and one of the first things they do in this culture is build a bunch of fires. So there's about 6 or 7 fires spread across the beach, and each victim is pulled in. And the very first thing they do is hold that patient above the fire. So I kind of like to joke is that their approach is FABC, meaning fire ABC. And again, they're just doing the best they can. This is what they've been taught in their culture. But it's no different than what we saw centuries ago. Now here some police officers have found a child who has drowned, and their first action is to put that child on their back and run around in circles. Again, if you watch this whole video, this goes on for 10 or 12 minutes. And if you look at the kid's face, he actually seems to be alive. And I like to say it's a face that's just starving for oxygen, because that's what he needs. But again, these police officers are doing what they've been trained to do. I don't like to discourage what they're doing because they're doing the best they can. I promise you, someone did this at some point and it worked and became the standard. So you can see how just a little bit of lack of knowledge and understanding of the science can have a huge effect on how we treat patients. Because this would probably have the same effect as putting the patient on top of an animal and having the animal run around. And then here we see just very inefficient poolside CPR. So again, these bystanders are doing the best they can, but you can see a small amount of knowledge or training could improve CPR and also put a focus on the airway. They're doing the best they can for this child, but it's probably going to have the same outcome as if that lifeguard made a simple machine and rocked the patient back and forth, because they're not treating the problem. And finally, I've scoured the internet for videos of blowing smoke up someone's ass as a treatment. Luckily, I cannot find those, so this is the only one I could find, but luckily it seems like we've probably phased that treatment out. So moving along, what type of burden does drowning actually have around the world? Well, most are surprised to know it's around 400,000 deaths per year from drowning. I think that's much higher than most people would expect. And it's important to understand this is a gross underestimate. This usually doesn't include things like suicide or homicide. In countries like Ireland, suicide by drowning is actually a big problem. It often doesn't include natural disasters. So if a tsunami comes through and wipes out a couple hundred people, most of which probably died from drowning, it doesn't count those. And say a ferry flips over and 100 people drown, often doesn't include those as well. So it's a very gross underestimate. Additionally, it depends on the country and what kind of data collection system they have. In many countries, this data is collected by someone who's just interested in this topic, and they collect newspaper clippings, and that is their only data source. So again, the quality of data is a huge issue around the world. In the U.S., this is obviously a big problem. It is a leading cause of injury death to 1 to 4-year-olds, and around 4,000 deaths per year. Primarily a disease of the young. Again, 0 to 4-year-old, 1 to 4-year-olds, 5 to 10 are kind of the biggest burden. It affects all age groups, obviously, but mainly a disease of the young. And in Florida, around 400 deaths per year from drowning. We continually lead the U.S. in drowning deaths, which makes sense. Our access to water and our weather, but again, a big burden of disease in our small children. So kind of parsing out those age groups, I like to talk about this real quick. On the left, we have our infants. In the middle, we have toddlers. And on the right, we have our teenage and 20s. So in terms of total deaths, toddlers often lead the way. And that kind of makes sense. I always joke that I have a 4-year-old and a 6-year-old currently, and their job from the time the sun comes up to goes down is to try and hurt themselves and try to make dad look stupid. So toddlers are called toddlers because they toddle around. They get into trouble. So if you have a pool out back or in the neighborhood that doesn't have a good barrier, they can easily get into it. At this age, they're starting to build confidence. Some of them may have had some rudimentary swim lessons. So this is a very high-risk age group. Bathtubs, it makes sense that our infants lead the way in deaths and injury from that. Mom and dad or babysitter, whoever puts the child in the bathtub, goes away for a minute or two to go do something, and the child can't hold themselves up and has now gone under the water. Even worse, sometimes a sibling has actually held the child underwater in an attempt to play with them. When we talk about pools, again, toddlers lead the way with this. A toy might fall in the pool and they go after it, or they just are interested and want to jump in, but they don't have the ability to keep themselves above the water. And then for natural water, our teenage and 20s start leading the way with death and injury. And so this makes sense. So these folks often have some swimming ability and they have built some confidence, but now they get into water that has conditions that they can't handle. So maybe they're able to swim in a pool, but now they're in a rough ocean or they're in a river that's running fast and they aren't able to keep themselves up. Also, alcohol starts playing an issue, and then things like boating and high-risk activities. So it's important to quickly touch on what drowning is and what it isn't. I don't expect anyone to walk away knowing this and memorizing this, but I think it's important to have in the back of your head. Often, especially in pre-hospital phase, as lifeguards and EMTs and medics, we may be the first line of defense for good information and to avoid bad information. So it's important to understand that there were many different definitions for what drowning is. The study looked at 60 years of literature and found 33 different definitions for drowning. Now that wouldn't really stand for any other disease state. If you went to a doctor who diagnosed you with diabetes and then you went to a different doctor who had a different definition for what diabetes is, you're not going to get treated right, and we're not going to collect the right data. So as it shouldn't stand for diabetes, it also shouldn't stand for drowning. So, for this reason, in 2002, a group of international experts came together and developed what's called the uniform definition. It is important to understand that this definition has been accepted by all major entities and governing bodies that deal with healthcare and health science and medicine. If anyone tells you differently, they are wrong. This is the current uniform definition for drowning. And that definition is the process of experiencing respiratory impairment due to submersion or immersion in a liquid. So what this definition says is if your airway falls below the surface of the water, and because of that you now have trouble breathing, you are determined to be a drowning patient. It doesn't have to do with you living, dying, what circumstances led up to it. If your airway falls below the surface of the water and you have breathing trouble because of that, you are now drowning. So we have to use some common sense. I always get asked, well, I went under rope for a second and came up coughing. Was I a drowning patient? Or I was eating dinner last night and my drink went down the wrong pipe and I started coughing. Was I a drowning patient? Well, no. You have to use some common sense. This is prolonged symptoms of respiratory impairment or respiratory dysfunction due to your airway being below the surface of the water. Now, from that primary definition, we can have three major outcomes. No morbidity. Morbidity is just a fancy word for injury. So someone can go underwater, have a drowning, come up coughing, sputtering, have some symptoms for a while, and then walk away and be fine. This is actually the majority of the patients we pull out of the ocean at the beach as lifeguards. There can be morbidity, which is just any type of injury. So lung injury, brain injury, anything you can think of, and the mortality, which is death. Now, along these lines, when they made that uniform definition, they also came up with a list of terms we need to avoid. The most important one is near drowning. I hear this term almost every day. And I like to say that you can't have a near pregnancy, you can't have a near gunshot wound, you can't have a near drowning. You either drown or you don't, based on the uniform definition. It seems like nitpicky details, but it's important when we start talking about data collection and treating patients, we need to be speaking the same language. And the term near drowning, based on the current definition of drowning, does not make sense. Dry and wet drowning. Very confusing terms. The term dry drowning was initially used in the 70s as an autopsy term. When they had patients who were thought to have drowned or known to drown, and then they go on the autopsy and there's no fluid in the lungs, they called that a dry drowning. And the idea was that there's probably laryngospasm in the airway that didn't allow water to get in. Since then, they've reevaluated that data, and they're not sure if that's a true entity or not, but it doesn't matter. Clinically, it doesn't matter. But the problem is the term dry drowning has now come to mean someone who goes swimming or is exposed to water, and then a couple of days down the road, they start having some type of symptoms or dying, and it's chalked up to them having a dry drowning a couple of days ago. Patients can have subclinical symptoms for drowning, but it's important to understand the drowning process starts at that time in the water. So they may have symptoms that are subclinical and not detected, but to say someone drowned 2 or 3 days later while being on land, or that's what dry drowning means, doesn't make sense. And this is a big deal. We had one a couple of years ago in Texas. The small child was swimming in a reservoir and 2 or 3 days later woke up with shortness of breath sleeping and went to the hospital and died. And the well-intentioned doctor said, "Oh, I'm sorry, but your child died from dry drowning." And then this massive news spree went across the world that every major news agency picked up this story. And it just does a big disservice to those of us who are doing drowning science and collecting data and trying to push the right terms. Because now we have patients coming to the hospital saying, "Oh, my kid was swimming last week and now they're coughing. I'm worried about dry drowning." And it just sends a wrong message out there. Yes, we need to worry about patients who have symptoms after having a drowning incident or after swimming, but the term dry drowning just doesn't make sense. And going back to that case I talked about, as we all expected, we got the autopsy report back and the patient didn't die from anything that had to do with drowning. The patient actually had an infection of the heart, had myocarditis. So again, we have this huge news story going across the world about dry drowning, and it had nothing to do with the patient's exposure to water. Along those same lines is secondary drowning. So secondary drowning, or people call parking lot drowning, again, what this means, what people mean for it to mean is they go swimming and a couple hours later in the parking lot and then they suddenly have shortness of breath and drop down, and it's called secondary drowning. But again, we like to stick to that primary drowning definition. Yes, the person may have had a drowning incident that's now becoming clinical, but that process started in the water. It didn't start when they're standing in the parking lot. So again, it seems nitpicky detail, but this was a study that we presented a few years back at the World Conference on Drowning Prevention in Malaysia. And over the past 10 years, we've still seen of the drowning literature in the highest quality scientific literature, 30 to 40% of papers still using terms like near drowning. So it's just a process, and we're still just trying to improve this across the scientific community. So what about the drowning process? I kind of always get asked about the drowning process, and this is the only slide I have on it because it's not important to understand each step. You can talk about the struggle, you can talk about voluntary gasps and all this stuff, but it doesn't matter how you describe it as long as you have the same end result. As long as you understand the end result of the process, that's hypoxia, then you understand what's going on. A lack of oxygen is what we have to worry about, and that's the most important step of the drowning process. We also have to kind of restructure our thinking of drowning. We've always thought about drowning as the disease of the lungs, but the lungs in general we can fix. Often we can, when the patient gets to the hospital, we can allow time to fix lung parenchyma. We can put them on vents and do all these fancy treatments to fix the lungs. What we can't often fix is the brain. Brain tissue does not recover well. So we have to restructure our thinking and think of drowning as a disease of the brain, because once that brain tissue is gone, it tends to not come back. So again, when you're the person on scene who's in charge of the scene and you are looking at all the treatments that are going on, you have to think in the back of your head, is this treatment that we are doing, is this reversing hypoxia, and is this saving brain tissue? Because then you're going to do the most amount of good. So on the topic of treatment, I always put a little more weight on the pre-hospital phase because that's the most important phase. If a patient gets to us with devastating brain injury due to lack of oxygen, there's not much I can do in the hospital. We can probably keep that person in the ICU and then help get them home to their family to live out whatever life they can. But in this first 5 minutes, especially with our lifeguards, our EMTs and medics, that is the most amount of good. That is the fork in the road that determines where this patient goes. So when you are that person on scene showing up, you need to think in the back of your head, okay, the problem is hypoxia. How do I treat that? Well, how do we treat hypoxia? We reverse the hypoxia by giving oxygen. And you're going to give oxygen any way you possibly can, any modality you have. Is that a bag valve mask with or without oxygen? Is that a pocket mask? Is that a mouth-to-mouth if you're willing to do that? Any way you possibly can. And I like to hammer this home by showing what I call my dumb slide. It makes sense. It's an easy slide to understand, but it really kind of hammers home what I'm talking about. Now, the number 21 on the left, that represents the amount of air we breathe around us. 0 on the right, that represents a drowning patient who's dead on the beach who's not breathing. That's how much oxygen they're getting. So 21 is greater than 0. It's always greater than 0. It'll forever be greater than 0. 16% is what we breathe out of our mouth. That will always be greater than 0. So if you go and bag a patient without oxygen hooked up, you're bagging 21%. It's greater than 0. If you pull out your pocket mask and start giving mouth to mouth or a pocket mask to mouth, you are giving greater than 0. You're doing the most amount of good. So don't think you need fancy setups. Don't think that you need oxygen. Be the first person on scene to start giving these patients positive pressure ventilation any way you can. You're going to do the most amount of good. Now, another important thing to be able to see and realize is that most severe drowning patients are going to have some sort of material coming out of their airway. This can be a couple things. As water enters the airways and lungs, it mixes with surfactant and causes this kind of foamy material. Also, this person, while they're in the water, was gasping and trying to save their own life, so they have some gastric distension. So they're also going to have vomiting from this, because now you have a person, especially in this scene, doing very inappropriate CPR and pushing on the stomach. So you have a lot of things coming up. It's just important to see this and anticipate it, because again, if you're on scene, this is a chaotic scene, and you may need to be the one to take a step back and say, hey guys, what are we doing? We need to do the right things. So in any textbook you read, when you see an airway like that, it's going to tell you to suction out the airway. You're going to suction for 10 seconds and reevaluate. Then you're going to suction for 10 or 15 more seconds and reevaluate again. If stuff's still coming out, you can consider putting the person in the recovery position on their side to allow it to drain out. That's great and all, but we need to keep in the back of their heads that while we're doing this, the oxygen level, whatever level is left in this patient, continues to decrease. So doing all these modalities, they aren't going to do much, and they actually might do a disservice to the patient. This isn't a process that just stops. It's not you get a little bit of this foam water out, okay, it stops, we're good. This is a process that continues to go. So while it's going on, we need to go ahead and try to get positive pressure ventilations in this patient. If you can bag this patient, if you can do mouth to mask and get ventilations in this patient, you're going to do the most amount of good. Instead of sitting there for 1 or 2 minutes, allowing the oxygen levels to continue to decrease. If you try positive pressure ventilations and can't get them in, then you can do whatever modalities or treatments you need to do to clear that airway. You can go in with suction, you can turn them on their side real quick, whatever you need to do, but with the idea in your head, hey, we are going to do this for 10 seconds and immediately get them on their back and try ventilations again. So we're not having 1, 2, 3 minutes pass by without any treatment at all. Now, to further kind of talk about the hypoxia aspect of this, we need to be able to differentiate 2 different patient groups. So we have this patient here. He came to the beach. He had Taco Bell for the 3rd time that day, didn't take any of his medications, never went in the water. He just grabbed his chest and slumped over, and now he's pulseless. This is very different from this patient, who we pull out of the water pulseless from a presumed drowning incident. And we have to be able to divide these patients because often they get clumped together. When we talk about treatment algorithms and data, they get clumped together, and that's very inappropriate because they're very different treatments. This patient right here probably had a heart attack. He probably had a clogged artery in his heart, and now he doesn't have blood flow to the heart muscle, and he went into an arrhythmia. So the reason his heart decompensated is because of lack of blood flow. Up until that point, his oxygen level is pretty good. He's breathing pretty well, so he can maintain the oxygen for a while. I like to describe this as a full tank of gas with a broken engine. So again, his oxygen, which is his gas, he's got a full tank up to the point that his engine breaks. Now his problem is a broken engine. Eventually, he'll need to refill the gas, but first off, we need to go ahead and just be his engine for him. So the way we treat these patients is we have to be their engine, and that's where compressions come in. And that's why compression-only CPR has become such a popular thing, because it encourages bystanders who would otherwise not treat these patients because they don't want to do mouth-to-mouth. It encourages them to go ahead and start doing compressions. Eventually, again, they're going to need oxygen. Now, there's never been a great study showing that compression-only CPR saves more lives because it's better or a better treatment. It just can save more lives because it encourages more people to actually do CPR. So in these patients who have a primary cardiac issue, compression-only CPR is a good thing. That's very different from our drowning patients. Their problem is different. They don't necessarily have a clogged artery. Most of these patients are young, healthy people. The reason their heart decompensated is due to a lack of oxygen. They got to a point where their oxygen level got so low that their heart muscle suffered, and now they went into cardiac arrest. This is a different type of patient. This patient has an empty tank of gas. Like I said, most of these patients are young and healthy. They have a good engine. Their engine isn't the problem. It's that they ran out of gas. So while we need to do compressions, we also need to provide ventilations. We need to fill their tank with gas. If we're not filling the tank and we're just doing compressions, we're not doing much good. And this is important because in many communities, compression-only CPR is pushed very hard. They say, hey, come take a 20, 30-minute class, take a 5-minute class even, and we'll teach you compression-only CPR. And people walk away from it thinking they know how to treat patients. And they do for the most part when it comes to adults. But then if they're at that pool party where a kid goes under and is pulled out of the pool pulseless from drowning, and they just do compressions for 10 minutes while the ambulance comes, they're really not doing much good. It's better than nothing. It definitely is, but we'd rather have someone trained to reverse the cause. So if there's ever a chance that you're going to be around someone in a pool, around drowning, around a kid, you need to try and learn traditional CPR with ventilation because you're going to do the most amount of good. And for those of us who are able to read heart rhythms, to send this home a little more, that patient on top, that cardiac arrest patient, the most common rhythm they go into is VFib or VTAC. And if you're trained in this, you know that the way we treat those is we give compressions and we shock them out of it. 90% of patients who have drowning cardiac arrest are in asystole or PEA. And the way you treat that is compressions and reversing the cause. And reversing the cause in this case is hypoxia. So we have to keep that in mind. All right, so that's kind of was a quick focus on the goals of treatment. Now a little bit more about pre-hospital care. This is the drowning chain of survival, and it's like cardiac arrest chain of survival, stroke chain of survival. It just kind of shows the most important links in the chain. So obviously on the left we have prevent drowning. Now there's so many different things that go into that. That's a lecture in and of itself. But in the middle, before we provide care, we recognize distress, provide flotation, remove from water. Now, as a pre-hospital providers, you may be called to do this, but we need to remember to not get ourselves in a situation we shouldn't be in. Every year, people die trying to save others from drowning. So instead of one victim, we now have 2 or 3 victims. This happens all the time, and we have pre-hospital rescuers that happens to. We have professional lifeguards that this happens to. So we all want to be heroes and do the most amount of good, but if you become a victim yourself, you're not doing any good at all. So we need to take a step back and kind of go back to our Boy Scout, Girl Scout brain and say, hey, can I reach something to this patient? Can I throw something to it? Is there a craft I can row to this patient? Taking that extra 30 seconds to look around and say, hey, how can I safely get to this patient? If you don't have formal training in professional open water life saving, now you're going to avoid having an additional victim on your hands. So if we have the patient safely to shore or on a stable surface, we can start our initial resuscitation. So it's the same at pre-hospital as it is in the hospital. Like I said, first goal needs to be reverse hypoxemia or hypoxia. So the way we can do that is first we can just provide oxygen any way possible. If this patient's awake and talking to and generally looking okay, we can just try to keep their O2 sat above 95%. If that's with a non-rebreather, great. If that's with a nasal cannula, great. If that's with room air, awesome. You're not going to hurt these patients by giving them oxygen. So our lifeguards, usually we pull someone in the back of the truck, even if they look okay, while we sit there and gather information from them, we'll just throw a non-rebreather on them. Again, just try to keep that O2 sat above 95%. If they're having respiratory distress, that's pretty serious, or apnea, then obviously we want to give them positive pressure ventilation. So that's usually going to be initially through the form of a bag valve mask. There is some evidence for CPAP or BiPAP if you have that on your rig or in your protocols. There's a couple studies that show this helps avoid intubation. We obviously need to be careful with patients if they have a lot of liquid or fluid coming out of their mouth. That's probably not going to be the best one for CPAP. We need to think about their mental status. And also it's important to know if they don't turn around on CPAP or BiPAP in the first 5 or 10 minutes, we probably need to go ahead and think about intubation. So ultimately, the sickest patients are probably going to get intubated. These can be very difficult intubations. Again, we often have a lot of crap coming out of the airway. This may be in a hard environment on the beach, in a hot environment with a crowd around. So just anticipate a very difficult intubation with this. Supraglottic devices, this always comes up in discussion. It's lots of people's protocols. It is indicated for drowning patients. There's not great science on it. There's a couple studies showing success. There's also some showing that the pressures within the lungs from injured lungs may go beyond the leak pressure of the supraglottic device and cause it to fail. But if it's in your protocol, I think it's worth trying off the bat because, again, this can be very tough intubations, or at least having as a rescue device on hand if you aren't able to get the intubation. But we always advocate for if all else fails, just go back to your basics. Think about very good, high-quality bag valve mask. That's going to be much better than sitting there mucking around with a very difficult airway and missing the intubation. Once a patient gets intubated, in terms of ventilation or putting the patient on mechanical ventilation, the ARDSNet protocol is generally what people will follow. There's no great science to this specific to drowning, but this is an acute lung injury. So most people will try to avoid very high pressures, try to augment your PEEP to avoid very high pressures and very high levels, toxic levels of oxygen. But in the pre-hospital phase, just do whatever your protocols say and get the patient to definitive care. And then in terms of circulation, try to keep this patient's blood pressure up. There's evidence that patients with low blood pressure after drowning have increased mortality. This can mainly be due to hypoxia. But if you have patients refractory to treatment with still low blood pressure, we can do IV fluids and also pressors if needed. Also, in terms of circulation, the question comes up of how do we do CPR on these patients? There's no great science on this specific to drowning. Like I said, we all would agree, all of us in the field agree that ventilations need to be a part of that chain of treatment. We would also, most of us advocate for 5 initial breaths. This is not based on any great science. It's based on cases that people have seen where just those initial breaths alone cause a patient to regain consciousness and regain a pulse or a palpable pulse. And then knowing that hypoxia is the main problem. So whatever way you do it, it's fine. Follow your local protocols for CPR. Just try to make sure you have ventilations in that CPR process. Hypothermia is always a topic because providers ask, I've heard of stories of patients being underwater for a long time. They come out, and because the water was cold, they then survive. They do really well. Well, there are case studies of patients being submerged around an hour and doing fine. There's a case a couple years ago of a child undergoing 88 minutes of CPR and walking out of the hospital 3 days later. We need to know that this is the exception, not the rule. Almost across the board, this is very small patients who fall into icy water. So they're very small children who have a relative large surface area, a body surface area, who fall into icy water and therefore have a very rapid cooling. A majority of patients that get pulled out of the water who are cold is because they've just been in the water a long time. It's actually a very poor prognostic factor. So if you have a small child in icy water, yes, then that might portend some increased chances of neurologic survival. But in general, patients who, especially in cardiac arrest or cold, we need to actively rewarm them. We treat this like any other cardiac arrest hypothermia patient. So don't be scared to rewarm these patients, especially if they're in cardiac arrest. Pre-hospital phase, C-spine injury always comes up, and whether we need to worry about this. Yes and no. Most studies we look at, C-spine injury is actually very rare in drowning patients. It's extremely rare. And the patients who have C-spine injury, they have a known mechanism for it. So if someone says, oh, I just saw them dive head first, or they just jumped off that pier, or they have obvious facial trauma with bruising and blood and stuff. Other than that, the vast majority of patients who drown don't have an injury. They just were in water they couldn't survive in, and they drowned. So the problem is these patients get pulled out and all the focus gets put on C-spine immobilization. So all the focus is taken away from proper resuscitation. And now you have a patient with a complicated airway with a bunch of fluid and stuff coming out of the airway. You're now strapping down to board. We'll show a video at the end that shows this really well. So if this is in your protocols, because some places have a protocol that every drowning patient gets backboarded, you need to seriously rethink your protocols and talk to your medical direction, because this is actually a very dangerous practice. If you have a high suspicion for C-spine injury, have someone up there holding inline stabilization on the C-spine with their hands. Otherwise, skip the backboard, especially these patients in cardiac arrest. Get these patients stabilized, get their hypoxia reversed, and get them to definitive care. You can protect their C-spine and other measures, but by focusing on C-spine injury and C-spine immobilization, we take the focus away from important resuscitative measures. Also a hot topic is abdominal thrust. Abdominal thrusts were pushed for a long time in drowning patients. The idea was to rid the airway of water. We need to not be doing this. There's very few agencies left doing this, but there's still a couple out there, and this is something we've been fighting hard against. And the problem is the main person who was pushing it was Dr. Heimlich. So abdominal thrust, also known as the Heimlich maneuver, and he was pushing this pretty hard in the drowning community. And it's interesting that a lot of his data was actually found to be falsified, and it was found and uncovered by his own son. But he had a lot of really shady data out there that was backing this measure. We had a lot of water park agencies that were still doing abdominal thrust. And the problem is twofold. First off, again, you're taking the focus away from proper resuscitation. So when you give abdominal thrust for 30 seconds to 60 seconds, you're now not giving ventilations during that time. Secondly, you're taking an already complicated airway and thrusting on this patient's stomach, causing more stomach contents to come up. So you may be on scene where someone comes up and says, hey, we need to give them the Heimlich maneuver, or hey, we need to do abdominal thrust. You say, hey, I need you to go call 911. And then you go ahead and keep treating the patient as you know how. And then AEDs. This gets brought up a lot. Are AEDs safe on patients who drowned? Are AEDs safe on wet patients? Are AEDs necessary? So like I said, 90% of the patients who are in cardiac arrest from drowning don't have a shockable rhythm. So probably not necessary. They may be, because some patients do drown from having a heart attack. They might be swimming in the water and they have a heart attack, VFib or VTAC, and then they drown because of it. They could also have a shockable rhythm from drowning. So yes, it is a part of the treatment, but if you're the only responder, focus on proper CPR first. And then when someone else comes along and they say, hey, do you want to get an AED? Sure, go ahead and get that. But don't let the AED take away from proper resuscitation. Also, AEDs are safe to use on wet patients and in wet environments. You just need to make sure you towel off the chest and that the pads have good contact with the patient. If you're on a wet environment around the patient, the studies have shown that you're actually safe to go ahead and defibrillate that patient as well. It's not pre-hospital disposition. Disposition is just a fancy word with what do we do with these patients. There's not great science on this, but there is some pretty cool data from a friend of mine, David Spielsman, who is a medical doctor down in Brazil. And his job was the medical director of drowning resuscitation centers. They had so many drownings in places like Rio that they had specialized clinics along the beach that they would bring these patients to. And he has a database of thousands of patients. And they took a look at these, and what they did was look at the outcome of the patient and then correlate that with the initial vital signs, initial physical exam findings to figure out, hey, based on what the lifeguard initially saw, what happened to these patients. And he was able to divide them up into 6 different classifications. Not the best science in the world, but it's what we have right now. So what he found was the class 1 patients, they had mild or no cough and a normal lung exam. So when listening to lungs, they had normal lung sounds. These patients had 0% mortality. This is their class 1 patient. As the patients had increased cough and rails or crackles in some lung fields, their mortality went up a little bit to 1%. What this showed was just they had some damage to lungs that was perceived on auscultation. As they started getting foam coming out of the airway and rails in all lung fields, the mortality went to 5%. Once they had hypotension, increased foam in the airways and rails in all lung fields, the hypotension being the main thing, mortality went to 20%. Respiratory arrest, mortality 44%. You may be surprised that in a lot of studies we look at, when someone comes out in full cardiac arrest from a drowning, mortality is very high, especially if they make it to the hospital and still in cardiac arrest. It's a very dismal outcome. They may survive, but with a dismal neurologic injury. So you can kind of divide these classifications into mild, moderate, and severe. And as general recommendations, every agency is going to be different, but general recommendations, those class 1 mild patients you can release with education. This is what our lifeguards do. Like I said, majority of the patients who pull out of the water are class 1. They may be coughing, a little short of breath when you get them off. 5 minutes down the road when they're sitting on the truck getting treated, they're starting to turn around, looking good, speaking well, maintaining well, normal lung fields. We generally send these patients home. Once you start getting abnormal lung sounds and persistent cough, especially hypotension, ultramental status, all that, those patients should be transported, or at least you should recommend transport to advanced care, so they at least be observed. They might be discharged from the hospital quickly, but we can at least observe them, because we do know from the science that patients can decompensate in the first 4 to 8 hours. Usually decompensation happens in that first 8 hours, most of all in the first 4 hours, so we want to be able to watch those patients a little longer. I'll show these different classifications. I like to use footage from the show Bondi Lifeguards. I initially thought this show was going to be pretty lame because Hollywood essentially has done a disservice to lifeguards over the years. But it's actually pretty cool because it's real life footage from real patients from the lifeguard's perspective. And so you can see what real drowning injury looks like. So I'm going to show you 3 different drowning cases. The first one's going to be mild, second one will be moderate, and the last one will be severe. And then we'll kind of talk about each one after they're over. This first one's going to be a little girl that's pulled out of the water by a lifeguard and then brought into shore.
Okay, stay here with me.
So as we can see there, that little girl is pulled out of the water by a lifeguard. She's immediately talking to him. She kind of looks okay. If you watch the rest of the video, he brings her in the shore. She looks okay. Mom's there, and he releases them with education. Doesn't do a very thorough exam, but just by the submersion time and by looking at the kid looks good. So that's that kid, especially if you're a lifeguard, to say, hey, you guys go ahead and rest, watch your child. If anything gets worse, please come back to me. But generally, they're going to be safe. This next one's going to be more of a moderate case. This is a tough case because, as they say in the video, the kid's been drinking on the beach all day with a group of friends. So it's hard to tell, is he drunk or is he altered from a lack of oxygen? But you can see if you look at this patient, he's a little sicker than that little girl.
Maxie has just rescued 16-year-old Jason from the rip at South Bondi. He's one of a group of boys who'd been drinking illegally on the beach minutes earlier. More lifeguards back up. Oxygen will help Jason breathe if he's taken water into his lungs.
So, open your eyes for me. Good boy. You swallow any water?
So as you can see, that guy's a little sicker. He's not acting right. He's a little lethargic. Could be that he's been drinking all day, but also could be a lack of oxygen. So they're having to keep a mask on him. He's not answering questions well. He can't really sit up. So that guy's obviously a little bit sicker. He's not in respiratory or cardiac arrest, so he's kind of that moderate phase, but he definitely needs to go to the hospital for further observation. And this last case is going to be a case of full cardiac arrest from drowning. So I want you to kind of see the response of lifeguards and then how they deal with the crowd as well. This is a patient in cardiac arrest.
Bugs. Copy, mate. Safety group, middle of the main set, man. Quick, get there.
Do you want to be there on the shore?
Sure. Yeah, mate, you're gonna have to get there.
Chapo and Kalen are half a kilometre away at South End.
Yeah, middle of the main set. Blue Jays, can you get there? Hard to tell yet, man, but I think they got someone on the back of the skate. Yeah, can you get into dick here, mate?
That's alright. Oi! Oi! Bring him up, oi! Hey, get him out of the water, get him out of the water. We're gonna get him out of the water. Get him out of the water. Ready? And then we'll start compressions up here. Okay. Yeah, come on. Get a mask, get a mask. Yeah, we need a mask, mask. Okay, who's doing? I'm going. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Get the back, come on, get it. 14, 16, someone back in. 20. I'm just going to keep going until you guys keep going. Just keep going, okay? I'm just going until...
Can I get that, get Ellen?
He's now been clinically dead for 3 minutes.
21, 22. Keep going, Chappo. Someone give Chappo a break.
All right. Wait. Go.
Right,
Hey, mate, can you... Hey, please.
get back, mate.
Yeah, but we're happy we've done this a lot of time.
Keep going, Maxie. Okay, two breaths, mate. 1.
Just slow down.
Let's go. Pads on.
Just stop talking over each other.
5, 6, 7.
So as you can see in that video, that patient's in full cardiac arrest. So a couple good things I like to bring up. If you listen to the beginning of the video when they're running, getting the patient off the jet ski, the person in charge is saying, get a mask, get a mask, get a mask. And I think that shows he understands the process of drowning, understands his goal of treatment. He needs to get oxygen into this patient. The other thing I love in this, because any drowning on the beach or in the field anywhere is going to be a chaotic scene. You're going to have a crowd around you, more people than you possibly need. But I love that the anesthesiologist kept trying to butt in and help. And the lifeguard said, we've done this a bunch of times, we know what we're doing. If you look at the resuscitation, it's true. They know what they're doing. And I tell my 16-year-old lifeguards, you're allowed to say that to anyone who comes around. If you know what you're doing, you understand the goal of treatment, and you're doing proper resuscitation, no one else out there is going to do better than you. It doesn't matter what kind of doctor, nurse, EMT, medic, whatever they are. So just keep that in the back of your mind. You may be the only one in the scene that actually understands the goal of treatment of drowning. So if you understand that and you know how to do the basic resuscitation, keep going and have that other person say, hey, do you know how to do CPR? Come help us out. Or have you called 911? But just know that if you understand the goal, you're doing the best that anyone else can. So now prognosis. Everyone always wants to know what's going to happen with these patients. That we pulled a kid out from a drowning incident. What's going to happen with them? Not so much a question you might have to answer in the field, but you might be curious, or you might get asked this by the family. Now the science on this is not great at all, but what we know about every study we've looked at on this topic is that the leading prognostic factor is submersion durations. The amount of time the patient's underwater is the one thing that truly correlates with outcome. And that makes sense because the amount of time they're underwater correlates with what level of hypoxia they've experienced, so how long they've been without oxygen. In general, patients less than 10 minutes submersion, that's known submersion time, are a better prognostic indicator. Now, someone can be submerged for a couple minutes and still die, but less than 10 minutes, they have a better chance of survival based on other patients. If it's a known submersion greater than 25 minutes, it's a pretty poor prognostic factor. So, again, you're not going to really be able to answer this question right off the bat. It takes a couple of days to figure these things out. But if you know a little kid was under for 30 seconds or a minute, he has the best chance of survival. If you know that kid was missing for 40 minutes and then found underwater, things probably aren't going to play out very well. All the studies have also shown no association between patient age, water temperature, or witnessed or unwitnessed event. Again, the water temperature comes into play with very small children in icy water, but in general, it's pretty rare. I'm going to wrap up with a couple more videos. This is just to show another true life resuscitation. And while we watch this, you want to keep in your head all the things we've learned over the past 40 minutes or so, and the goals of treatment, and things we should avoid, and things we should focus on. And just while you're watching this, keep in the back of your mind what's going well, what's not going well, and how can we improve on this. Now, this was a case from Huntington Beach back in 2012, and I never show this to discount anything these guards are doing. Huntington Beach guards are some of the best guards in the country. They're very well trained. They have good protocols and systems in place, but you can see how even in a well-trained team, very small deviations in the best treatment pathway can kind of take you down a road that you don't want to go down.
It's 5 or 10 minutes since we got her out of the water.
Get the resuscitator out.
Back up. Back up. Let the lifeguard take it off.
30 minutes.
Don't touch the patient. Set up the resuscitator. Grab the back out of that cell.
Jenny, 40. Just like good here is 2022. Both our jobs, towers. Thank you.
Continue CPR.
So in that first clip, I think a couple things we can take away from it. Very good initiative and professionalism. I think the person in charge, the guy in the white shirt, is doing a very good job of delegating tasks to different people and kind of taking a whole global view of the situation. Their CPR is good. It's 30 to 2. They have no advanced airway in, but good compression rate. They put the AED on early. It says no shock advised, and as we discussed before, that's probably because this person's in non-shockable rhythm. The main thing to take away from that is always have an airway person. Initially, there's an airway person up there, but they kind of move away to go do something else. You can see now the team leader has now had to move into that position. So now we'll continue on with the next clip. I'd just like to say that the airway device they're using in the next clip has like a demand valve. So it's a mask that you hold on the patient, and then you press a button, and it gives them a positive pressure ventilation. So we're continuing the resuscitation here. The only thing I like to bring up in that clip, and this is going to be protocol specific, is that stay and play versus load and go. Now there's a lot of discussion in cardiac arrest these days of do we stay and play or do we load and go. It's well thought that any well-trained EMS agency can provide just as good of an initial resuscitation as I can in my resus bay. And by loading a patient too quickly, we're going to overlook things like quality CPR, early defibrillation. So some agencies have gone to a stay-in-place situation, especially maybe for the first 15-20 minutes of a cardiac arrest. The only reason I bring it up in this case is you have a very crowded beach, not ideal conditions. You have about 30 or 40 people surrounding you. You have cameras in your face. You have dogs running around. So this is one of those things that it's good to talk to your agency about this and say, hey, maybe it's best to just get this patient out of the situation. We also see in the next clip where the ALS agency has to now come down the beach, bring all their equipment to you on the beach, which can be pretty difficult. So this may be a thing as a team leader, you step back and say, hey, we have a truck right next to us. Let's get the patient in there and let's meet our ALS agency at the next beach access. For a couple reasons. First off, it makes that transition a little bit easier. It gets you out of, and it gets your folks out of a very high stress situation. A lot of these guards, you can tell, just pulled this patient out of the water. They're tired. Your CPR is starting to look a little sloppy, and now you've got cameras around and people around you. So you kind of look like a rock star agency if you start this resuscitation, throw the patient in the truck, and get out of there, and then you're gone. But as you sit here for 20, 30 minutes, and this goes on and on, you just run the risk of starting to look a little sloppy.
Family or friends around here of the victim? Do we know the victim?
Yes, lots and lots of salt water.
So now we've seen the ALS crew arrive. They're in the blue uniforms. And I will note that the reason there's all this footage and cameras around is because they were filming a documentary, kind of a real-life lifeguard documentary. That's why there's professional cameras around. ALS crew gets there. A couple important points. So you can start seeing the focus veering away from reversing hypoxia. There is an airway person, but they spent 45 seconds trying to clear the airway with a suction device. So we talked about that. That's foam and water doesn't stop coming out. So they spend a lot of time trying to clear that airway instead of giving ventilations. So about 45 seconds without ventilations. You can also see one thing that kind of becomes the fork in the road. So the leader starts putting a C-collar on this patient. You can see how that single maneuver right there, again, instead of just loading this patient up and going, that single maneuver takes this resuscitation down a road we don't want to go down. You can see the focus of treatment at this point on becomes spinal, protecting the spine and spinal mobilization and not giving good ventilations. So we talked earlier about the idea that it's probably better just to do basic bag valve mask ventilation, positive pressure ventilations, and try and intubate these patients on scene. What you have now is an ALS provider who's laying in the sand on a hot sunny day with a crowd and cameras and dogs around him, with foam and water spewing out of someone's airway, undergoing CPR. I can almost guarantee you that tube didn't get in the right place. Maybe it did, but I'd be very surprised. It has to be one of the hardest intubations I can possibly imagine. Also, because they're now attempting intubation, he's now asking the provider to stop CPR. So CPR is important in these patients. And now we've stopped for 40 seconds to try to get the intubation. So again, in this case, I would just opt for bagging this patient, getting him in the truck, and getting him to definitive care.
Ready. Ready.
So this is the end of that video, and if we watch all out, you can see that there is 90 seconds without ventilations, and the reason for that is cervical immobilization has become the priority. This patient is dead, and I cannot think of a situation where we need to fully backboard and immobilize a dead patient. So now the focus of treatment has become immobilization. If you watch the whole video, they put the head blocks on, they do all the straps, everything. They're rolling the patient in a coordinated attempt, but the entire time, a minute and a half without a breath. So we've now, at this point, forgotten our goals of treatment and focused on the wrong thing. Again, in no way do I demean what these folks are doing. These are highly trained individuals. But you can see how not having someone taking a step back as a leader and saying, hold on, what are we doing? Let's skip all this and just go. By not having that person on scene, we start going down treatment paths that we shouldn't be going down. Overall, I think great teamwork and technical skill. Always room for improvement, but the big takeaways are don't wait, resuscitate, and prioritize ventilations when treating these patients.